Here we are, 2025 ASMBS, Washington, D.C., and I am honored and privileged to have the opportunity to sit here and talk to Dr. Peterson, the incoming president of ASMBS. And he has got multiple initiatives he'd love to discuss with the surgeon community as well as the community at large. So Dr. Peterson,
yes,
if you'd like to go ahead and start, what would you like to start talking about here at ASMBS and what do you think is the biggest initiative that you really want to focus on?
Yeah, so I'm actually really happy. Each of us, as we come into the year, we choose a theme, okay, for the year. This current theme right now is, ending the stigma of obesity and bias. And I chose, kind of in the era, you're probably well aware that the GLP-1s have kind of taken off, which in a positive way has helped elevate the awareness of obesity as a disease because, now there's a pill or shot for it. Obviously we've been treating obesity for a long time with surgery, but a lot of our members are hurting. Their volumes are down. We know that, and so really my theme came from kind of my military background, and so it's no one left behind. Now, what I mean by that is it's not just our members who are suffering. I don't want to leave our surgeons behind. I don't want to leave our integrated health members who are here behind. But most importantly, we don't want to leave our patients behind. And that's the problem, is that there's a gap in the treatment of obesity. So for sure, that theme, I think, resonates for kind of in the era we're at right now with that.
And you were talking about the stigma. I think part of it, and we know that in the general population, there's this belief system that you just need to eat less or you just need to diet and exercise more, which reality we know that that data is out there and it doesn't work. But even then, in the medical community, there's a stigma. And
you're right.
As part of your initiatives, like one of your first initiatives is educating. Can you kind of walk me through what is the educational plan that you're looking at and why do we have to do that?
So thank you. That's exactly right. So the kind of the number one initiative that I put forward is this putting an obesity curriculum in schools. And so I was a little myopic when I first thought about it because, coming from medical school where I teach residents and I teach students. So the third year students would get one lecture in their third year on obesity. And I used to do that with an OBGYN who did the medical management stuff, and we had a psychologist. So the three of us would give a 3-hour lecture, an hour apiece, and the students would go off into small groups and talk about it. And that was their only lecture they got for all 4 years. And somehow that got pulled. So we don't have that anymore.
Wait, they got rid of it?
They did.
So they had one 3-hour series.
That's right. And so it made me think okay, I can't be the only school that has this problem, right? And so I started looking around and I'm hearing more and more about it. And then what I found was, so we just did this amazing obesity summit last year where we had 40 different organizations that partnered up with us as well as our industry partners who came to the table and just had this huge discussion about trying to move the needle, if you will. And what kept coming up, though, this theme, and we'll talk about it at our business meeting here at the meeting, because there'll be a summary report of the Obesity Summit, was education is lacking. It's huge. And so what I figured out was it's not just the medical schools. So the nurse practitioners in their training aren't getting anything, and the PAs aren't getting any training. So there's a lot of groups missing, and these are our frontline people, right? This is who's seeing patients for the first time, and so that's a huge gap. Now I know that's not going to change anything tomorrow, but we want to treat more people, we want to care for more people with this disease of obesity, but we have been trying for years and aren't doing anything. That needle has not moved. We still only treat 1% of eligible patients with surgery. So what I know is we haven't changed the minds of the people who are treating the patients to start with. So if they don't think it's a disease, then we're never going to move that needle. So I kind of think like this education, think of like the stock market. This is for the long haul. That's the long game. We're going to get in there, hopefully help people remove that bias about obesity when they start going into their own practices. But then we have to move the needle on the people who are already practicing and help them understand, as you said, Jeremy, this isn't a willpower problem. We know that this is a disease.
Yeah. Well, the more I've been able to talk to all the amazing surgeons that we've had, today, and then of course in the pre-interview sessions I got to have with them, I find the whole thing so mind-blowing at the system level, from the environment that we've created for the humans that are living in these different countries, the United States being the forefront of it, how it's just failing everybody. It's failing everybody on the insurance side, it's failing everybody on the government side, it's failing people on the food distribution and the food side, and on the pharmaceutical side, because we create a disease and the pharmacy comes in and says, we got a treatment for your disease. It's like, yeah, but that's not the sole solution, that's not the panacea that's going to fix this. I mean, this is a problem that's affecting every aspect of medicine. Every doctor is seeing it, and 70% of the U.S. population is, fighting this on their own, and being told that they're failing because they can't seem to accomplish it. And it's like, wow, who's not affected by this?
Right. I mean, think about it. I remember when I started a bariatric program, right after I got out of the military, I went to a small community hospital and we started a bariatric surgery program there. And the first day I was doing a bariatric surgery patient, the guy next to me doing the gallbladder, his patient's BMI was higher than the BMI on the patient I was operating on. It affects every aspect of it, right? The disease of obesity is pervasive, and it's not just people seeking surgery. I mean, everyone. It impacts everything, every aspect of folks' care, and unfortunately, a lot of people are just trying to treat the comorbid condition that is secondary to the disease of obesity, but trying to take down the hypertension, trying to make the diabetes better. But we're kind of missing the point if we're not taking care of the root problem. I kind of see that as the same problem as, we can't expect that we're going to change anyone and be less biased about what we do if we don't actually help fix their bias to begin with as, new doctors and nurse practitioners and PAs. That's got to change. And so my hope is to form a task force this year as one of my initiatives, and that task force will include multiple organizations, not just be an ASMBS. We'll lead it, but we do need multiple organizations that are all involved. We talked to the American College of Physicians. They were at that meeting, the summit. I happened to be lucky enough to sit next to one of their members. And when it comes to medical school and testing, who are we testing? Well, we're not testing obesity because it's not taught. It's not taught as an organ system. That's the thing. Organ systems are what we go back, I tried to remember medical school, and I'm like, I remember we talked about the heart, right? So you learn about all the things that are associated with that organ. Obesity is not an organ. And the thing is, obesity is in every organ system. So it's really trying to figure that part out, is how do we then encourage testing of that so that we can actually move forward from there.
And do you see this as something that's a stigma that starts in the home as a child? I mean, it seems like I grew up blue collar, Midwestern, and it was always, if you're overweight, it's your own fault.
Yeah.
And I really think that is a difficult problem to really change fundamentally in the population, because it's easy then for the other constituencies involved in this, let's say, that may be worsening the problem, to just say, well, it's not our issue.
We have inherent bias, even as medical practitioners, we have a bias in the office. We don't see that disease, or oftentimes how is it treated? We're working on your diabetes, you're working on your hypertension. Oh, and as I'm leaving the room, by the way, you probably should lose some weight. Okay, well, how and what to do? And of course now we have better options, but it's really not. Maybe I should have started the visit with, okay, you have this, and it's hard because people do feel blame and feel shame about the disease of obesity. But anytime I'm talking to a patient and I say, you have a disease, and they kind of look at me like, what, really? And then I say, if this was cancer, you wouldn't be feeling the shame of this disease, because cancer is a disease that you didn't ask for, and you didn't ask for obesity. It is part of your genetic makeup, it is part of your metabolism. So we've got to move out of that. I know that's what Dr. Rogers in her year really was trying to help remove that stigma, remove that bias. And hopefully, and again, I didn't get any training in obesity in medical school. It wasn't until I was a resident, first year we had a bariatric surgery program that started, so I know as an adult learner, when you get there, you can change your mind. You can get past that level and start to realize that this is something that's real. This is a real disease, and you can try to move the bias away.
And today, a lot of the leadership from ASMBS was on the Hill, because we're here in DC.
Yep.
And what kind of response did you feel that you got from them?
Yeah.
Do you think that that's where the conversations need to really start occurring?
So, a lot of the two main initiatives that we talked about on the Hill today were that TROA, which is the Treat and Reduce Obesity Act. That's been going on for years. I think this is the 13th year it's making its way back onto it. And that one is really trying to get more treatment options. Like they treat, surgery is treated with Medicare, or Medicare does cover surgery rather, but its guidelines are old, 1991 guidelines.
1991?
Right, so that's the thing. I mean, we updated the guidelines in 2022 with the ASMBS and IFSO, put forward new guidelines that were evidence-based, not just expert opinion, because the 1991 guidelines were just expert opinion.
I was 11.
Right.
It was 11.
Yeah, that's what I'm saying.
It wasn't even, it wasn't considered chronic disease yet in 1991. It wasn't considered epidemic yet in 1991. No. And you weren't looking at 70% of your population having a problem in 1991.
Right.
But that blows my mind. I'm sorry.
But think about it. I mean, you've been doing surgery. What other thing that you do you do because that's what they did 30 years ago? I don't know. There might be some old school hernia type of technique.
I'm trying to think. We don't even prep the same. There's not a single aspect of the.
Nothing.
Maybe the Foley catheter might be the same.
Right. The OR is maybe the scalpel looks similar. That's it. But it's completely changed. Now, why on earth are we still going with these old criteria?
So, what was the name of the bill that we're talking about?
The name of the bill that's continuing to go forward is called TROA, the Treat and Reduce Obesity Act. Now, that's been pushed forward for about 13 years. A lot of senators have supported that, and it goes forward. It just never quite makes it across because obesity isn't really seen as the disease it is.
So what's the purpose of that bill? What are we trying to accomplish with this?
That one, really, it's actually trying to get medical coverage for obesity. So we already have surgical coverage. Also trying to get lifestyle intervention coverage. So Medicare will cover, let's say, a dietitian to see a patient if they have diabetes, but they won't cover their visits if they have the disease of obesity without other comorbidities.
So am I incorrect in understanding this? Because everybody that I talk to always says we need to focus more on prevention than intervention.
Right.
And you're trying to get them to focus on prevention instead of intervention. Mm-hmm. And now for 13 years they've said no.
Right, and it's the sad part is it's not even, is it really prevention anymore? 30% of the population, or a little bit over 30% of the population, are already in a category that would qualify for surgery. So why on earth, are we preventing the other 60% potentially from getting there? I'm not even sure. Maybe that part of it is resistant to the disease. Or maybe there's a subset in there that would have the disease if we weren't doing preventative measures. But how about we prevent the worsening of other comorbidities that the people who already have the disease have? That's, I think, what we really have to push. And that's what we were actually looking at with the Medicare guidelines. We were trying to look at getting them to adopt the 2022 criteria. So we want to push that forward. And that's some of the work we're going to be doing over the next few weeks, is trying to get that to change.
And that's from a Medicare standpoint. Where are we on the private insurers standpoint?
Right. Well, as you kind of are well aware, most insurers follow Medicare guidelines. So, but we've been somewhat successful. I wouldn't say somewhat, successful. We've been doing well getting insurers to realize that there is a new set of criteria and that they are beginning to adopt it. So there are definitely some that are adopting that. And to your point, we already have surgeries we're doing now that we weren't doing 30 years ago. So we really have to, get that expansion, because some insurers don't even cover some of the newer, and I say newer, endorsed procedures since 2019. The ASMBS started endorsing an operation called the SADI, right?
I keep going back to 1991.
Right.
In 1991, you're doing what, open ruin, maybe, were we doing open ruin noise in 91?
That's right. We were doing so. Yes, in fact, I remember. So, my age. You were 11. I was, I guess, 21. Okay, fine, or 20ish, whatever. So, but I remember my mom when I was a kid. Had a friend. My mom battled her weight her whole life. My dad as well. But one of her friends went and had gastric stapling. So in that time, gastric stapling really meant just truly stapling with no division. So they didn't divide the stomach, they just stapled the stomach and made it a smaller pouch. Well, I mean, yeah, so we were doing these big open operations, and death rates were higher back in the day of open surgery. I mean, now our surgeries are safer than gallbladders, safer than getting your appendix removed. I mean, that's just what the data shows. So we've come so far, and we have new interventions. And, there are old interventions that we don't really endorse anymore, that that are still in some of the old guidelines. You're like, well, we don't even do that operation anymore. We need to clean it up.
So why is it? I mean, while we're talking, I keep going back in my head thinking the thing that's affecting our entire population, by far, probably more than any other medical problem in the population, and our government hasn't updated their way we're going to handle this from Medicare since 1991.
Well, they looked at it in 2000. So the Medicare started covering covering surgery in 2006, based on that criteria.
It seems like this may be something we should be focusing on.
You would think. I don't disagree with you whatsoever.
Well, we'll table that for a second and just go back to, so look at your initiatives though. And you like I said, you have 4 major initiatives, and you're also looking accessing comprehensive obesity treatment, which is part of what you were discussing here.
Right.
Updating the core guidelines. You were a major portion, or you were a major backer of the SOARD, the SOARD.
Yeah, SOARD. Yeah, that's our surgical journal, and so that's actually the society's journal, and so a lot of our work gets published in there. So we wanted to make sure we were aligned with the what SOARD is looking to let us publish and how we publish it, clean that up. And then, the last initiative, which is, and you know what, you're helping us do that right now, which is I want to improve the image of what we do. I would say, unfortunately, the public only has an image of a bariatric surgeon in 2 contexts. My 600-Pound Life, this show, and another show called Botched Bariatric. So I'm not putting those down, but I'm just saying that's a show that people see. And it's, obviously sensationalism is what, helps sell things. But I mean, the vast majority, almost all of the surgeons I can really think of in our space just have such compassion and empathy, and that's really not visualized well. And so I want that image out there. And my hope is that obviously you're going to be interviewing people throughout, and I know you're not just looking to interview our leadership. You want to really do the man on the street kind of interviews and talk to people, and I think that's awesome. I am excited for that because I'd love for this to be more public facing at some point so that they get to see that, wow, that doctor's not so crazy. That doctor seems really nice. Because this is a different place, right? When you're doing cancer care, you need compassion. When you're doing this kind of care, obesity care, you need compassion. And it's not like you came in for a gallbladder, it gets cut out. You say thank you, and you tell them you're welcome, and then they go home. This is lifelong, commitment to each other.
I think that I've definitely been impressed, and I've actually had the opportunity in the last 3 years to work with ASMBS at various parts of your meeting. Each year has been more involved, and it is a level of compassion that I think is overlooked by the rest of the specialties, and what it takes to, because this is a patient population that they've failed, and they don't, I hate to say fail because they're trying. Like, it is hard to look at somebody who wants to lose weight. That they've spent a lot of time trying to do this, and they see themselves as failures. At the same time, they're in an environment that's built for them to fail. And then the insurance companies aren't necessarily there to support them, and their doctors have said, well, it's on you, or inadvertently made them feel like it's their fault. Yeah. And then they get to the bariatric surgeon, and you're the experts at medical, surgical, everything obesity related, and finally somebody's going to have to say, it's okay. Like, you're trying, we understand you're trying, and yet this is where we're at, and how do we help you?
Yeah.
that's a tough position for both sides to be in. And I think that in my discussions that I've had with various members of your society, they all come across as just amazingly competent, but also compassionate people.
Yeah. I think, because you think about, you go back to surgical residency and you think about how many times did you get that consult about the mass in their colon or whatever, and you go in and you're like, hi Miss Jones, I'm here, we're here to talk to you about the mass in your colon, and they're like, what? Now you were unprepared, you didn't know, and I think we've all learned, like, it's crazy to me, but it's not uncommon that I will get a patient who's referred to me from my own institution, so I know that they're in the medical record system, and I look and I'm the first person to put obesity as the disease on their problem list. It's like crazy to me. Yet it's just people have a difficult time recognizing that as a disease and aren't talking to them about the disease, don't have the ability to do that, and they're afraid to talk to them about it. And the patients are afraid to ask about it. And so trying to normalize that this conversation is okay, I think is really important.
I also think that, going back to GLP-1s, I do think that the way that they've helped people as a doctor, I am afraid to bring it up because I don't want to offend them.
Yeah.
And at the same time, it's like, we know that it's having an effect on you. We know that this is most likely, especially if they're significantly overweight, they probably want to find a solution, but they also don't want to be stigmatized, and they don't want to be told this or feel like, okay, fine, tell me that. What are you going to do about it? I've been trying. I can't figure anything out. So the least of GLP-1s, you see people taking them and losing weight, and you're like, oh, you recognize. We all agree that this is something that needs to be managed better.
Agreed. Well, I mean, it has absolutely raised the awareness about the disease. And I think that's critical. And I think some patients, again, I think of it as a oncology model. There's neoadjuvant therapy, there's adjuvant therapy, there's surgical therapy with adjuvant therapy. I mean, it's just, we need to think of it that way. This is a chronic disease that isn't going away with just one thing. Yeah. And some people will do great with medication only. That's great. They're great responders to it. But they have to be on it for their life. Surgery, some people respond to surgery alone and they don't need anything more either. But then there's that group who's in the middle, and we're learning who should benefit from the combo therapy. But it's, we have to work together. And then we have endoscopic therapies out there now that are showing some promise. So absolutely, there's this whole continuum of care that's really critical. And I think you said, you alluded to it. You said, patients feel like they failed, and that's just it, is that they, nothing is failing the patients, and the patients aren't failures, yet they are made to feel that way, and that's what so many people come in. The first time I tell them that they have the disease, they have tears in their eyes because somebody kind of just told them it's not their fault, and it isn't their fault. Now, look, the environment. I would say there's environmental factors. There's, diet and exercise. Okay, those are the only two things that a person can control with relationship to this. Like somebody who smokes and gets lung cancer, they can control if they can smoke or not. But at the end of the day, that's a small part of the factor. Because if that was a big part of the factor, people would just diet and exercise, and there wouldn't be obesity as an issue. But that's just not the truth. Nobody gets to change their genetics. Nobody gets to change who their parents are. Again, environmental factors play a role, which is why it's just not surgery. It's surgery with lifestyle changes. We do things like that. But, really understanding the disease more comprehensively, which is why, the ASMBS is not just surgeons. We have our integrated health partners here who are all a big part of that continuum of care.
Absolutely.
Yeah.
And I'm very excited. Obviously, I'm going to talk about it since this won't come out until after the meeting, but we are going to be working with you and partnering with you guys.
Yes.
It's exciting to get all this information, this education, and be able to put it on the platform and make it easily accessible to our surgeons to really allow them to see everything that you're doing, but also get a better understanding. As you said, it's part of educating the rest of us and letting us better understand what is this as a chronic disease. Why is it that obesity is so challenging to manage? And putting that information at the palm of our hands so that we can really access it easily. I'm very excited about this.
Yeah, no, me too. I mean, honestly, we've had some conversations before, and as eye-opening to me that the platform that you're all providing, I think it can give us another place to have another voice. I think we all respond to things differently. I'm old enough that I started the Facebook stuff for ASMBS. That was kind of how I started, my rise in the society was really working on that area because I was all into Facebook. It was I could turn on my phone, it was easy, I was there, and you realize that there's a group who like that. There's a group who like, there's groups who like Instagram and Twitter, and I'm not on those platforms, and I see LinkedIn's rising up, but this is a place where that platform we get to really do things. We have these webinars. I mean, that was my first experience was on a webinar and enjoying. I mean, I was kind of getting, beaten down a little bit on this is how you do a paraesophageal hernia. Whoa. But I had fun. And I think people who watch were having fun. And that's kind of part of it too, is enjoying, getting the joy back in what we do. I think that's really important. And you guys are doing a phenomenal job with that.
Well, thank you. No, like I said, we're very excited about this opportunity to work with you. And I think that getting out really explaining what your patients are going through and how we can work with the bariatric surgeons in our own communities and better really treat this disease, because it's going to take all of us coming together to make this happen.
I agree.
So, but that being said, I always like to end. My favorite question is, what is that pearl of wisdom? What is that thing that you only learned because of experience in your field and it didn't come from any textbooks that you would like to get out and explain to somebody else?
Oh, wow, man, that is, you're just throwing that right out at me.
Yeah.
What is the one pearl?
Well, as we pointed out, now you've been around for quite a few years now, so.
I have been around for
this
quite a while.
This is where wisdom comes from, right?
So basically you're telling me that the gray in the beard is telling you that, no. The pearl of wisdom that I've learned in treating patients, listen. Listen to the patient, and be there for them. Be their champion. Because in our world, our patients need cheerleaders. They need someone who really, that they can actually trust. And I mean, I know in surgery, they have to trust us because they put their lives in our hands. But the reality is that this is just kind of for the first time, someone who's telling them it's not their fault.
No, I think that's actually very important. And in your field, I said, I have noticed you're surrounded by a lot of amazing surgeons that really believe in that.
Yeah.
And I'm glad you exist, because this may be the only time that those patients ever get to hear that.
Agreed.
So thank you so much for your time.
Thank you.
Looking forward to your meeting coming up this evening.
Awesome.
And
Thank you.
I can't wait for the future work that we're going to have together.
Me too.
Thank you.
Thank you so much.